Okay, so today I'm going to talk about this trial from 2015 by Chris Littlewood. It's called A Self-Managed Single Exercise Program versus Usual Physiotherapy Treatment for Rotator Cuff Tendinopathy, a randomised controlled trial, or we can just call it the self-study. Before I go any further, I want to talk about what's highlighted here in pink, this phrase rotator cuff tendinopathy, which might not be familiar to some people. But it's basically a term that Chris Littlewood and many others are beginning to use as a replacement for these terms. And I've stolen this slide from Chris Littlewood to explain the point here. Subacromial impingement syndrome is the one I'm used to, but I also often hear bursitis, supraspinatus, tendinopathy, that kind of thing. The problem with all these phrases are they're very specific about what the primary cause of this shoulder pain is, but we know now that our clinical assessment, our clinical tests, and also imaging techniques can't pinpoint a primary cause of that kind of shoulder pain. So these kind of terms aren't appropriate. The other problem with them is that they can be seen as quite fear-inducing to patients, especially this word impingement often puts fear into patients that movement is and pain is causing progressive damage to their shoulder. So this phrase rotator cuff tendinopathy is seen as a more appropriate phrase because it accounts for the uncertainty around the diagnosis and is also a lot less fear-inducing for patients. So to help me assess this paper, I'm going to use this CASP tool, and first of all we're going to answer this question: did the trial address a clearly focused issue? So the issue is kind of there in the title. Littlewood here explains that he's a bit concerned that there's such a range of potential conservative approaches to rotator cuff tendinopathy. He suspects that one single exercise might be beneficial and would also be preferable for the patient as well, and probably increase adherence. And here he summarizes the aim of the trial, which is to say that it's aiming to evaluate the effectiveness of a self-managed, loaded single exercise program versus usual physiotherapy treatment for rotator cuff tendinopathy. So we need to find out a few other things. What about the population studied? Is that clearly focused? Well, we have that up here. This is the inclusion-exclusion criteria. This is for identifying what rotator cuff tendinopathy is. It's basically to make sure it's not a frozen shoulder or there's no kind of reduced range of motion there. There's no shoulder special tests you'll notice for the criteria because they're just really big old barrel of balls, not very good at all for the shoulder. And here is the exclusion criteria, and basically what he's doing is he's letting in as many people as possible to the trial. So often you'll see that people are excluded on the basis of comorbidities like diabetes, heart disease and so on, but we want this trial to be as applicable to our patients as possible, and many if not most of them do have other things going on. So all the participants in this trial are not excluded on the basis of comorbidities. We want to find out about the intervention given. He explains that in a nice specific way here. 3 sets of 10 to 15 repetitions twice a day is the key thing, but also here exercise prescription is guided by a symptomatic response requiring that pain is produced during exercise. That means that remains no worse upon cessation of that exercise. So rather than prescribing exercise not to go into pain or to go up to some arbitrary number on the NRS scale like 5 out of 10, he's saying that any pain that's acceptable to the patient is fine. And that's really important because it means he's decoupling hurt and harm. He's trying to communicate to the patient that a bit of pain isn't going to make their shoulder any more damaged. And here a little bit more information about the exercise program. I just put this picture in to see what they're doing Really, doesn't take very much time at all. It's kind of as you're making your morning cup of coffee, that kind of thing. Unusual physiotherapy is a range of interventions, advice, stretching. There's actually a really nice table down here showing what people end up getting in the trial. And we can see that the self-management group, the intervention group, everyone's basically getting exercise and education, not much of anything else. In usual physiotherapy, everyone's getting exercise as well, a little bit less education and advice, but also a lot more of other stuff: stabilization, mobilization, stretches, even some massage and taping as well. So that gives us a nice clear idea of who's getting what in this trial. So we know about the comparator. In terms of the outcomes, it's the SPADI, which I think is pretty standard. And he says here, very helpful, it's been validated for use with this population, and the minimal clinically important difference is 10 points. So it does address a clearly focused issue. Let's have a look to see if it's randomized. A computer-generated randomization sequence was produced, so that's great. Were patients, health workers, and study personnel blinded? Well, no, unfortunately they weren't, which is pretty standard for a physiotherapy trial, but the data analysis was blinded, which is good. Were the groups similar at the start of the trial? So we want to make sure that no group has got a kind of head start against the other, which would skew the results. And here Littlewood explains that the groups were balanced at baseline. There's a little bit to do with the mean and the median, but without going too much into it, basically they balance out and the groups were similar at the start of the trial, which is very important. Question 5. Aside from the experimental intervention, were the groups treated equally? Well, one way we can look at this is how much time they were given, and 3.1 versus 3.4 treatment sessions is pretty much the same. There's no statistically significant difference between those two numbers. So that sort of means that no one group was getting much more contact time than the other group, which would definitely affect the results. And this is probably a good time to talk about the fact that this is a pragmatic trial at multiple centres, 3 different centres, National Health Service, presumably outpatient clinics in the UK. And this means that there's lots of kind of uncontrolled variables, lots of different health practitioners applying the treatments, that kind of thing, which reduces the kind of internal validity of the trial. So it's not one of those perfect kind of lab controlled explanatory trials. It's a pragmatic trial which has high external validity. So we can talk about that a little bit more later. But basically, crucially on that question of time, both groups were treated equally. Were all of the patients who entered the trial properly accounted for at its conclusion? So we want to make sure that they didn't just ignore the loss to follow-up, which tends to favour the intervention arm, and we can see here that they did do an attention to treat analysis, although I don't think they give us much information about how they did that. But this again is probably the biggest problem with this trial, unfortunately. In fact, before we show you that, let's have a look at the sample size calculation. They work out they want 34 participants per group and anticipate 15% loss to follow-up, and at 3 months, which is their primary outcome, they lose more to follow-up than they expect and include only 27 and 33 in the analysis, and that only declines thereafter. So unfortunately this trial ends up being a little bit underpowered, doesn't have enough people in it, and they're really open about this. They say that by 3 months 70% of patients had returned primary outcome data, and this diminished further by to 56%. Clearly the precision of the estimate of clinical effect is compromised, as is any attempt to infer beyond those patients who returned follow-up data. So this is, I think, compromise is a good word. This makes us kind of cast a slight element of doubt on the results of this trial. Nevertheless, all patients were properly accounted for. How large was the treatment effect? Well, let's finally, because I haven't even mentioned yet what the results were. And the results are here. So at 3 months, the single exercise group had a 12.4 point change on the SPADI. The usual physiotherapy group had a 16.7 point change, and those numbers are not statistically different. So they both improved at the same rate. And as things went on, without going into too much detail, both groups continued to improve. Tempting to say that the self-management group improved more, but really there wasn't a great deal of difference between them. So the conclusion of the authors is that both groups, or neither arm, outperformed the other, and both groups improved at the same rate. Also, both groups exceeded minimal clinically important difference of 10 on the SPADI, although only just, and the authors do mention here that other trials for rotator cuff tendinopathy have got a greater improvement than this trial, and they explain that might be because in this trial, after randomization, because of NHS waiting times, treatment didn't immediately commence, so that this kind of some people were a little bit sluggish to start for that reason. So how large was the treatment effect? Well, it was there. It was probably clinically important, although we can't compare it to a no treatment group, of course, so it might be natural history of the disease, a lot of it, and it was pretty moderate as well. Certainly wasn't large. How precise was the estimate of treatment effect? Well, we have p-values of less than 0.01. Confidence intervals are there, which is great. They're not narrow, but they're not particularly wide either. They don't overlap 0, but they do, both of them, I think, at 3 months overlap minimal clinically important difference. So there's a chance that the results aren't quite as clinically significant as we'd hope. Will the results help locally? So this is the great thing about having a pragmatic trial, is yes, certainly will. The conditions that patients were treated in this trial were very, very similar to the conditions I'll be in if I go on placement tomorrow, and the patients are very similar to the patients I'll see as well, so that's great. Were all clinically important outcomes considered? I'd say yes. Obviously, in an ideal world, there'd be enough funding and enough time to find out how much, for example, each intervention arm cost, that kind of thing, maybe more psychosocial outcomes, but the main thing is the SPADI, pain and disability, and we've got that. Excuse me. Are the benefits worth the harms and costs? Well, certainly, and we'd assume for the intervention arm the harms and costs are smaller than in the usual care arm. So that's the self-study. It seems to be a pretty convincing multi-centre pragmatic trial, which is really generalizable to practice, with the definite exception that unfortunately they didn't have enough people because of loss to follow-up, so there's a little bit of doubt cast on the results for that reason, but it's certainly quite persuasive as a suggestion that multimodal care, the kind of kitchen sink approach, if you like, or some people might see it as a tailored approach to sort of perceived different causes for rotator cuff tendinopathy, involving things like mobilization, stabilization, manual therapy, is not necessarily superior to unimodal care, that bread and butter thing of just doing the exercise to assist the condition to get better. So certainly I think it's a great paper because it challenges that current practice, which is what you want evidence to do, ruffles a few feathers, and makes you think.